Well, it's a pleasure to be here. So my topic is passing the limits of occluder therapy and when surgery is needed, and I'm happy to talk about that from a surgical standpoint. I think what I'm going to do for my presentation is just really show a case that I did recently, and we'll go through that a little bit. So as it's well known, obviously, that where's our? Hang on, sorry. There we go. Small technical problem. Percutaneous closure of the atrial septal defect is safe, it's effective, and commonly used, and we've heard a lot about that at the meeting today. And there's good data. If you look at the RESPECT trial, which enrolled 980 patients, they're randomized between medical therapy and device closure. The complication rates were low, but there were some complications, and some of them are rather severe, and include things like cardiac perforation, tamponade, endocarditis, things like that. So the therapy's not perfect, and there are some people who probably should be selected out, and some of those cases would include folks with multiple septal defects or very large defects, or those with kind of a deficiency of tissue around the defect, which would preclude proper seating of the device. So that's, I'm going to show a case like that. And this patient I just saw, this is just a couple months ago, a 58-year-old woman who was complaining of increasing dyspnea. She was really otherwise healthy, had not really interacted with the healthcare system much at all during her lifetime. Someone heard what they thought was a murmur on exam, and then this prompted echocardiography. So as you can see here, it's a fairly large defect. It's not the biggest. There are devices that can close fairly large defects, but the trouble here is specifically is a small, does this project here, my arrow? Well, in the retroaortic space here, there's really no tissue, and the rim is falls into this category of sort of a floppy rim, if you would. So again, here's another picture. There's obviously tremendous flow across the defect, and if you look at the 3D image, this is an atrial septal defect, which is really contiguous with a large patent foramen ovale. So, the concerns with this patient, we reviewed it. I reviewed it with my structural partner. We actually had a pediatric interventional guy look at this as well. A few people looked at it, and the concerns were really around the fact that it was large defects, floppy rim, lack of tissue in the retroaortic area. So, what are the options? Well, surgical treatment for ASD closure is something that's been around for a very long time. In Boulder, we don't like to open the sternum if we don't have to, so some of these we're approaching endoscopically. And the surgical risk is low, less than 1%. So, again, it's a safe, effective, proven therapy. Here's a picture of the defect through the scope. And again, this is measured in about 24 millimeters or so, but the greater concern is that the tissue surrounding this would perhaps not be ideal for landing an occlusion device. And just for the sake of orientation, there's the superior vena cava. You can identify that by the anesthesiologist's central line. But it's a big defect, and this was closed. Here's another picture through the scope with a bovine pericardial patch sewn in a couple layers. This patient did well, was discharged home in a couple days with no anticoagulation. So really the point of my talk is that the devices are great, they work very well, but there are still a few patients for whom good old-fashioned surgical closure is an excellent method, and we can close those defects that are sometimes more challenging for our interventional partners. Thank you very much.